Now it's time for our expert Q&A panel. And I would like to invite our experts on the panel up here. We have a hot seat where you can sit or you can stand around there if you would like. So we'll invite Dr. Julien Haroche, Dr. Eli Diamond, Dr. Ronald Gove, and yes, I will be here as well. And any questions you might have for the experts, and actually for anyone, any speakers so far that have given wonderful talks, please, this is your time to ask questions, and will help facilitate these questions. I think we need one more person if Dr. Go is not here. Maybe Jithma Abeykoon. Dr. Abeykoon, do you want to join? I'm sure several of you, especially in the back bench, who are paying attention, will have several questions for our speakers and experts here. So please, this is your time.
So these new targeted therapies, you get great responses. They're not a cure yet. I'm on the younger side, 45. So hopefully I'll have to take it for another 40 years. Probably will always take it because it's in my brain. So have we looked into what's the long-term effects of these drugs, taking them for 20, 30, 40 years?
I don't think I mean, the longest it's been used in histiocytosis is 15 years since the first patient. So, and in other diseases where it was developed, it was in cancers, and usually it was only 2 years maximum. So I don't think we have any longer treatment periods with targeted therapies. So I'm pretty much confident that all the side effects we know, and it's true, we don't have the follow-up after, we don't have signals of new diseases or new side effect after more than 7, 10 years. So I think the side effect we know are the side effect that probably will happen in the next 10, 20 years in your case, maybe, or I don't know.
Yeah, I think you bring up an important point. And in other cancers where these drugs are approved, the survival is not as long as it's in ECD, actually. And I would say we don't know long-term effects. And it is a concern, even if you have low-grade diarrhea or fatigue or nausea, if you have it for 5 years, that's not, it may not be serious adverse event, but it's still cumulative toxicity and intolerance. And actually, we did a study showing that nearly 30 to 40% patients treated on BRAF inhibitor, at least on the initial doses, had to come off. So now we are trying to, that's why, reducing the dose, doing dose breaks, and so forth. But this is also a plug-in for our survivorship study that we'll be talking about later, and we have a team here to talk about it, really to understand this question. What are the problems, health problems, including chronic health conditions that can happen from the treatments, especially, I think the targeted therapy has succeeded, but it's really a survivorship problem now with that. And second cancer is something I think all of us are trying to figure out why they happen and who they happen in. So thank you for your question.
And I'll just add, I think that the instances where I've seen where it seems like, 10, 12 years later, someone is in a rough shape and it's the result of treatment is when it was very high at the beginning. People who've been on low doses from the get-go, I don't have the feel that, you're now 10 years in and the real issue is toxicity of treatment. So I think what's been probably the high-dose vemurafenib was probably the roughest now in retrospect. And MEK inhibitors, especially started at low doses, I don't really feel like they have a snowball cumulative bad effect over long periods of time, although long is, 10 years now.
But like your question was more like on side effects or like long-term, yeah,
Health
okay.
problems. Yeah.
This is kind of addressing your concern, Ben. I've had this illness, and it was diagnosed since 2002, and I've been on various medications ever since. And at one of the regional ECDGA Global Alliance conferences, this guy, Dr. Gordon at UC San Diego, said, well, one of the good things that they've been finding is that when you are diagnosed and you're on a regimen, people seem to react very well to it. So then the question is, does it then become a status medication? I think the answer is yes. I've not only been on various medications, and I think what your doctors are trying to find out is how well you tolerate the dosage you're on. And in my case, also it's paired with 3 times a year surgical interventions for a stent change, because the main issue I have in my illness is kidney involvement. So I just wanted to mention that. Thank you.
Hello, doctors. Thank you so much, obviously, for being here.
Whoa, that's your effect.
Are we okay? We're back. I have a question about dosing, Dr. Diamond, and it's specific to me, so I hope it's appropriate, but I assume it is because we're all in this thing together. I take, the mechanism, the Taflenar, 7 days on, 7 days off, right? So I'm taking 7 days within 14 days is what I'm doing right now. And tell me what your thoughts are. Is this okay? Or if you tell me no, obviously I do what I'm told. Of taking 7 days within that 14 days. So let's say the first week I take it for 4 days. So I take it Monday, Tuesday, Wednesday, Thursday, and then I have the weekend off. That's kind of nice. Then the second week I take it 3 more days to make up my 7, which could be Tuesday, Wednesday, Thursday, let's say. And I do have my 7 days within 14. Does something like that make any sense? Is that a bad idea because you're not getting 7 days straight? That's my question.
So I think of sort of the total exposure over the month. You know what I mean? Is someone taking it half of the time, a third of the time, what percentage? And with the sort of days on, days off, it's a matter of what you're solving for. Some people, they get, like let's say they're on trametinib alone, and they get stomach aches and diarrhea. If I have people really pay attention to what happens over a month, they'll say, on this week on, week off, on day 5, I am in the bathroom all day, every day. So then I will make it like a 4 on, 4 off, so they never get to that day 5. So I don't think there's a big difference between 4 and 4, 7 and 7. It depends on what you're managing, and then I just think about what the total exposure is over the cycle.
So not a horrible idea.
No.
And do you feel any differences between on and off?
I want to be truthful. I've only kind of tried it now for a couple weeks, right? And no differences. And I was just doing it because my schedule, actually, I had kind of a weird schedule over a couple weeks, and I said, I'll take these 4 days and be off. And I said, oh, this is kind of nice, actually. It's a little easier to manage during the work week because you're more structured anyways. So if you think that's okay, I'll try it, and then I'll report back and let you know how it's going. Yes, sir.
And you have a dual therapy or just a MEK inhibitor?
Dual therapy.
Okay.
Yeah. And then just a statement, Dr. Diamond, the brain thing is real, right? As an emotional person before all this, I was clearly a 0 out of 10 as an emotional person. But, now I'm, maybe a 3 out of 10. So I feel things that I didn't feel before. And then all the anxiety and blah, blah, depression that may come along with all this other stuff, right? So it is real. And thank you for part of it with the fatigue and all that. Some of the the relief of just the anxiety or worrying about everything is just knowing I have the tools in the toolbox if I need them. Because, I don't take them all the time, but it's almost knowing that, oh, I have it if it's something, I can treat it and then go back off, So thank you.
Thank you for sharing your experience. Any other questions?
Hi. Thank you, doctors, for doing everything you do. I have idiopathic intracranial hypertension, and my neurologist doesn't know if it was caused by ECD, but I was just wondering if you guys knew if anybody else had it.
I would say that I've had like maybe 3 or 4 instances over 15 years where I felt like CSF absorption dynamics were referable to histiocytosis. So I would say not 0, but not common.
Okay.
Yeah.
All right. Thank you.
Sure.
So as we now have more people who will be on these target therapies for many years or decades, and we talked about the not really knowing about the side effects, what do we expect for the long-term efficacy of these targeted therapies? So if many of us are on 1 per day and we've done it for 5 years, what do we think about if it's 10 years or 15 years? And Dr. Diamond, you mentioned there are some cases where people low dose who see coming back. Is that there is potential for these stable doses continuing to have responses over long terms, or what is the thoughts on that?
I think, I don't know if my colleagues agree, I think there's probably some portion of patients who could stop and maybe they wouldn't realize, and we don't know who they are yet. I think we've been kind of scared off by, the sort of the findings that we've had here about relapses. And I do, maybe less so in the brain population, but I'm trying more to take people off and see what happens. And I have increasing instances of people who are off treatment for many years. So I think that we probably need to be a little bit more adventurous in stopping and seeing what happens. But I think that's kind of the lay of the land with the treatments that we have, and we're trying to find better ones at the same time.
And one other thing is, I agree with Dr. Diamond too. Unlike other diseases like some leukemia, when you stop it and if the disease comes back, most of the time the disease is responsive to the treatment that you were on. So that is why it is fine for us to okay, the patient is doing well, we did the scan, and the scan looks fine, do you want a drug holiday? If the patient says yes, and then we stop the drug and continue to follow closely, and as long as the patient looks fine and the imaging looks fine, it is fine to continue the drug holiday.
I agree. And I will even go further. I think that when you re-challenge, in the extreme majority of cases, I wouldn't say like most, I would say like even almost all patients will respond again. And in this period where you are off the drugs for many months or many years, you probably want to use maybe new or even biomarkers. You have like cell-free DNA and like PET and other imaging modalities, and obviously physical examinations to see if you're going to relapse and when. And you can also go back to very low dose. For instance, what we do is either nothing or very low dose interferon to try to avoid this relapse. So there are many ways to handle this situation when you are off the drug at one point, off targeted at one point.
Well, I'm sure everybody here, when you talk about potentially going off of the drug, is very interested in that. And so when would you decide for some people who have been on a low dose for 5 years, what would make the decision for them to potentially go off, and then what would the testing plan look like for those people? I mean, obviously lab work and MRIs, but like what would be the frequency of those in terms of specifically monitoring for relapse?
This is perhaps my voodoo. I treat people for 2 years before stopping because I tell myself if I'm treated for a year and then it comes back, I'm going to say, gosh, should I have done longer? But I think 2 is kind of like 2 is long. So if people have a complete response, like a negative PET for 2 years, then we have a conversation, hey, do you want to take the chance? And I'll usually do imaging probably like 4 to 6 months after we stop, just as like an early check to see if things have come back.
Yeah, I agree, and then I would say at least 2 years, but it depends. Obviously, it's a case-by-case decision. If you have a very high burden disease and you still improve after 2, 3, 4 years, and you have a regression of various sites of involvement, then it's probably the cases where you might want to be under treatment. And if you reach a plateau and that you don't get any better, then you can get out of the drug in these cases.
Does that
I think
differ
down the
with,
road you'll be able to, hopefully we'll be able to do studies to figure out, who are those people who we can safely stop. I think the early studies are concerning to us, but I also think now, after having so much experience in prescribing these drugs, we all have our way of, a calculated break of treatment, but also there are patients who we may not feel comfortable like saying, okay, you can completely go off without a plan. And I sometimes look at the remission duration. If the disease has not been in complete remission for some time, then it's a little bit hard, especially if it's in the brain, to justify taking a break. If it's outside the brain, it's a little more easier to justify that.
Yeah, I was going to ask the exact question. A lot of us have brain involvement. Have you ever, or would you ever take someone off that has significant brain involvement?
Well, I've tried a couple of times. I think pretty quickly with that whether that break is going to work or not clinically, as well as radiographically. But we don't have just very large data. It's just my own experience. I would say that if they are in remission for a long time, we can take holidays. And then also there are alternate dosing schedules, like we were discussing, that you can try. But you have to follow the clinical picture. I mean, what are the side effects that are experiencing? Is it cost issue? Or is it new health problem? Like this one person I took a break from developed atrial fibrillation. So we were trying to work on that. So we took a break, but the CNS symptoms came back. So we had to figure out to go back on some form of targeted treatment at that time. But I'm sure others have different way of.
I have instances of, BRAF, ECD in the brain, which I would have thought invariably would come back very quickly, which have not, and they stopped for another reason, some external reason they had to stop treatment. So, and these were people who were treated for a very long time before they stopped. So I don't think it's like 100% predictable.
Yeah, and I also had a patient, central brain involved, BRAF V600D on vemurafenib. We stopped after 3 years, and then patient relapsed back, restarted, treated for another 2 years or so, complete response, and stopped again and has not occurred back for about now 8 to 9 months. So that can happen too. One-time recurrence does not mean that it will come back again for sure.
So someone with an ECD diagnosis has a lot of neurological symptoms that we've talked about today. But I've also had a stroke. I'm also getting older. How do you parse between, or can you parse between the potential causes of the neurological symptoms that I'm experiencing?
No, that's very difficult. I mean, especially with age, I'm not saying for you, but especially with age and especially with, vascular type things, it's difficult. The speech imbalance and that sort of mood dysregulation that I mentioned, those can be with other neurologic entities, but those are kind of like an ECD anchor, and then the other stuff can be very challenging, especially when there's comorbidities.
Yeah, I think with the aging population, in any cancer survivors, it's really a challenge to tease out what's from the disease, what's from the treatment, and what's aging. But there's also this phenomenon of accelerated aging that has been demonstrated in many other cancers where, you know, you're just because of the function of the cancer and its treatments, you're aging a little more rapidly at the cellular level, and that can lead to health conditions. And that's why in our survivorship study, one of the things we are doing is we are comparing the individuals to a cohort of people without histiocytosis to figure out what is just because of aging or what not. But in practice right now, you know, we work closely with a neurologist, and you know, you look at the imaging, and comprehensive multidisciplinary evaluation is very important.
It's also the case with cardiovascular aspects. So it's both for CNS and cardiovascular aspects. And as many patients that have that are diagnosed with Erdheim-Chester disease are already a little bit old, it's true that if you add many years to it, then you have to take into account this aspect of the disease.
Just like to get the panel's viewpoint on this. I had this conversation with Dr. Goyal last Friday, and also last night with Kevin, wherever Kevin is. And there's varying opinions on it, but ECD in a particular patient often, as you know, affects a particular organ system. You stop treatment after very good, say, PET scan results, and maybe you say, oh, I'm going to take a break. And like Ron said, fine, you can do that, but unless you feel remarkably better by stopping, at this point, with what we know about this disease, it might not be worth stopping, because it'll come back, or can come back. But I'd like to get your opinions on whether or not it always comes back in the same organ system, or is it common for it to move around? And say, in my case, I have the aortic coating and other things, but if I stop treatment, it's always I'm almost nervous about trying that, because would it come back somewhere else and be, you know, in the brain or wherever, and now I have a worse problem than I had before, or is it typically just return where it was before? Does that make any sense? Long question.
I think it's an interesting question, and usually, but I don't have any percentages, but I would say most of the case you will relapse in the, like if you have 3 or 4 organs involved, you will relapse in those 3 or 4, and you're not going to have other types of involvement, but sometimes there is also another possibility which is more common with LCH or some ECD. When you have a BRAF mutated ECD, you can at one point, but it's a long time after, get neurodegenerative involvement, but which is not the same mechanism. So I would, in your case, but I don't know precisely your case, I would say that you will relapse most probably in the organs that are affected with your disease.
I agree, and I'll just say I don't think that starting the medication alters the natural history of that in the way that your question seems to be asking. I think that we kind of import that idea from other cancers that, oh, it's like we took this and then it popped up in the brain kind of thing. I don't think that analogy applies.
Other questions?
Probably should ask you in a couple weeks when we're there, but we'll probably forget maybe too. But I remember you'd taken her off for a couple weeks, she had some other symptoms of the dabrafenib. And then when we brought her back on, it was challenging, right? She had some, I think, difficulty coming back on, and you had to lower some doses, stuff like that. I guess going on a holiday or extended holiday, how concerning is it, or what's the thought in terms of you only have 2 choices right now for BRAF? Is that if she didn't tolerate the vimurafenib or the first one, and then she had a challenge coming back on the DBRAF, if we took a holiday, could it potentially be she's struggling with both those drugs and we don't have a choice after that? I mean, we can talk about it in a couple weeks, I guess, too.
Yeah, so just to rephrase the question is, if you switch from one BRAF inhibitor to other after taking a holiday, or any permutation combination, you know, does it make a difference in tolerance?
If she goes on a holiday,
yeah.
and she didn't tolerate vimurafenib or the first one at all, and then she was challenged when she came back off a short holiday on vimurafenib. If you take on a holiday and then she has to come back, what's the chance or potential risk that she can't tolerate?
Yeah, the interruptions are not good for everyone. Some people find that it's splitting the baby, and they're kind of miserable when they're on and they're miserable when they're off, and it's the starting and stopping that is the bad thing. So some people definitely are worse with the on-off idea. It's definitely cracks the case for many people, but makes some people feel awful. And then if you add the nuance of some people who are on 2 because for the purpose of canceling out each other's side effects, then it can become even more complicated with the time lapse between those.